have a very busy program because we will have 5 live cases. In between, we will switch, and we have 3 additional talks. Our colleague, Dr. Nienhaber, unfortunately is ill. However, his talk will be given by Dr. Scheinert from the Angiology Department out of Leipzig. And to start with the session, we like to introduce Dr. Koselli first, who will later on operate case 12. So I invite Dr. Koselli to give his talk and start the program with his introductions, please.
Once again, it's a terrific opportunity and a pleasure to be here. When Dr. Moore returns, please let him know that I express my gratitude for the invitation and to be on such an esteemed faculty. What Fred asked me to do was to try to give you some sense of our thoughts on the treatment and results of our treatment of descending thoracic and thoracoabdominal aortic aneurysms, but take that and use it as a nidus to move into really what we're doing more of today, and that is the stent graft treatment of thoracic aortic pathology. I actually got in the abdominal aortic stent grafting about 7 or 8 years ago, and have been putting stent grafts in the descending thoracic aorta now for about 5 years. How do we advance this? Nothing's happening. I come to you from this is the Texas Medical Center, and I'm actually with Baylor College of Medicine. We've had an interesting little transition over the last year or so. We've moved from the Methodist Hospital and placed me to St. Luke's and placed me at the Texas Heart Institute. And not only having had the opportunity to work for many years with Michael DeBakey, I'm now finding myself working side by side with Dr. Denton Cooley. So it's been an interesting go of things. We'll start with the historical perspective, and I think it's important for us to maintain our skills and maintain the excellent results that have been developed in the open treatment of thoracic aortic pathology, because I don't think that's going to go away. Quite certainly, hybrid procedures are going to be part and parcel of what we do in the future, so that our abilities in this open approach are going to remain important. You don't need to be reminded of the details in this particular audience, but through a left thoracotomy, it's been for quite a number of years now rather standard practice to replace descending thoracic aortic aneurysms with Dacron grafts, and with or without the use of left heart bypass. Incidentally, in our own work, although we use left heart bypass not infrequently in descending aneurysms, we've been unable to demonstrate conclusively and with statistical significance that left heart bypass actually reduces the incidence of paraplegia in such cases. But in patients who are compromised from a cardiac standpoint as well as from a renal standpoint, left heart bypass clearly has some utility. This is some work from Dr. Crawford in a review of 832 descending thoracic aortic aneurysms, and just demonstrates from the 70s and 80s through at least to the early 90s the remarkable improvement with the results specifically with mortality. Unlike stent grafting, which we'll get into here in a few minutes, the long-term aspect of the follow-up, the longevity and the durability of this approach has been known for some time and is demonstrated here in this particular Kaplan-Meier survival curve. This is from a personal experience of a little over 450 descending aneurysms in a review we completed a year or so ago, and the incidence of paraplegia is quite low, as well as the overall operative mortality. And this is all comers. But if you take a selected group of patients undergoing stent grafting, I'll show you some of the results of that here in a minute, the incidence of paraplegia and paraparesis, for instance, in Criado's work in descending stenting remains at about 4%. As I mentioned to you earlier, using left heart bypass versus no left heart bypass, we've been able to show that it's had an impact on paraplegia in these more limited aneurysms of the descending thoracic aorta. This doesn't quite hold true for the more extensive thoracoabdominal aortic aneurysms, as you can see here. Not an infrequently encountered situation in patients with, as shown here, Marfan syndrome, previous composite valve graft replacement, and now a dissection in a long thoracoabdominal aortic aneurysm. Within the few moments provided me, I'm not going to go through with you all the possibilities and efforts that have been made to reduce the incidence of paraplegia, but some that we've focused